All right, so we're gonna have some time for Q&A at the end. So, but if you want to tweet us your questions, you could go ahead and do that during the presentation. Um, I am Bon Ku. I am from Philadelphia, and I'll be presenting with Joni Saylor from IBM. So I practice as a emergency medicine physician, also an educator and a researcher, and this is the emergency room where I work. But this talk is really not geared towards healthcare professionals like me, but more of the design community at large. So I always resisted becoming a physician, but my parents pictured here, I think they brainwashed me at an early age to become one. They moved from South Korea to the United States. My aunt married a GI during the Korean War. And they worked in flea markets and gas stations to put me through college, so I kind of owe them to become a physician. And to me, and like most of my colleagues, residency training was long, isolating, demoralizing. Felt these symptoms of burnout, wanted to quit. And I thought this would go away when I became an attending physician, but really the healthcare system was broken, and I felt that it was breaking me. I was really pessimistic that I could do anything about it. I felt I wasn't making people healthier, and rather I was just delivering sick care. But really tapping into creativity, I think, helped me get out of that burnout, feel less of it as a physician. And this was really surprising to me because I don't think most people think of medicine as a creative field. And I think, but I really think the most underappreciated skill in physicians is creativity. And I really strongly believe that making people healthier, it's a creative process. It can be creative pursuit. And so we understand what that looks like what that creative process looks like in the arts and music and film. But what does that creative process look like in healthcare? And at my medical school, the creative process really comes through in the power of design. So we have taken a deep dive into design thinking, and for those who were at John Maida's talk on Saturday, he illustrates the three types of design: classical design thinking and computational design. So 4 years ago, I did something very strange and unusual. I went to my curriculum committee at my medical school, and I proposed a program teaching design thinking to medical students. So I got a lot of funny looks. No other med school in the country was doing this at that time. But I really felt that we lacked the skills to creatively problem solve. There was only one problem with this. I am not a designer, and I knew very little about design thinking. So I did what most academics do when we don't know about much. I just turned to Google and typed in design thinking. And I was like, design thinking in Stanford came up on the third hit. Let me check out what that is. And I sent a cold call email to one of the instructors there, David Janka, who happened to go to medical school. And I'm a little stressed out because at 6:07 in the morning, and curriculum committee approved my program. I'm like, I got to develop a curriculum and all that stuff, and invited David over from Stanford to Philadelphia to do an entry design thinking workshop for us. And I was just fascinated that there was a school out there that teaches design thinking methodology. So I had this hunch about 4 years ago that design thinking or design can make us become better doctors, that it could help us to be more creative. So I started reaching out to designers in the local area in Philadelphia, and I started visiting their spaces. I noticed that designers call their spaces like studios, not classrooms, which was interesting. So, and they had some consistent themes at these studios. There were simple, flexible spaces. A lot of the tables were on wheels. They could be easily reconfigured, and just look a lot different from the classrooms that I was used to. And there was whiteboards everywhere, and they were always writing stuff up on walls, I noticed. And I noticed designers love to show their work in these studios. And there were so many freaking Post-it notes everywhere, and I was like, well, I don't know what's going on. So what I did was we took our students out of these large lecture halls in medical schools, and we put them into design studios because we didn't have one at my medical school. So we collaborated with designers like Jeremy Beaudry, who directed the Design for Social Impact program at University of Arts in Philadelphia. And I said, hey, can you teach one of our workshops? And he said, sure. I was like, well, can we meet in your studio? Because I don't really have one. He was like, come on by. So we brought our students there, and Jeremy's been taught them some skills of prototyping, testing, and teaching them how to think more like a designer. We went into architecture firms and engaged with architects, learning how to, the process of designing spaces. And we eventually squatted in one of our facilities at our med school and built a design studio there. If you look in back of that picture, there's a big vault there, so it's actually in the Second Federal Reserve Bank. So it was just this graveyard of broken machines of medical equipment, and we just squatted and turned it into one of our design studios. So I think throughout this process, my biggest revelation from looking at the healthcare system through the lens of a designer was this. The products and services and systems of healthcare are designed so poorly. And I didn't begin to understand the complexity of the problems until really kind of taking on a design mindset. And I love this quote from the designer Bruce Mao. He spoke here on Friday. And in healthcare, there's no shortage of design fails. So I just want to share with you a few examples of my favorite design fails in the hospital. Here's that annoying hospital gown that many of us have worn. It's nearly impossible to figure out how to put on, exposes your buttocks all the time. Patients always ask me how to put it on. I still fumble after 11 years of working in a hospital. Students from the Parsons School of Design work with a company to design a kimono-inspired hospital gown. So I was like, wow, this is great. What took so long to do this? I wonder. These are some thermometers that we use in our emergency room, and it's very difficult to tell which ones are rectal and oral. On the top, there's a red and blue button. So our nursing staff hacked a solution to this problem with a permanent marker. And if you were a patient, you probably wouldn't want that rectal probe in your mouth, taking the temperature. In healthcare, our systems and devices really suck at exchanging and communicating data. This is otherwise known as interoperability. So here's one of my residents. He's taking a picture of an X-ray of a broken forearm with his phone and texting it to the on-call orthopedic surgeon because he can't access the image. It's crazy, I think. This is a flow diagram that one of my residents made, and it shows who to call when you're admitting a cardiology patient to the hospital. It's a complicated process. So this is just who to call to admit them. So instead of spending time with our patients, we were doing all this non-medical clerical work. This is a plastic bedpan. It's actually not that bad of a design for collecting urine from patients, but it's a terrible design when it's used as a hack to perform pelvic exams in the emergency room. So this is me empathizing what it's like to be a female patient sitting on a flip bedpan for a pelvic exam. It's not an ideal situation. Hospital environments have terrible noise pollution. Monitoring devices constantly scream alerts. Overhead speaker system blares loud messages all the time. So we partner with an architecture firm, Kieran Timberlake in Philadelphia, and we work with architects, and we put these sound sensors all over the emergency department. We measure noise levels, and here's a floor plan of the emergency department, and we're just hotspotting areas of loud noise. And we notice that the ambient noise gets as high as 70 decibels, so that's comparable to a vacuum cleaner. Our spaces are designed poorly. We routinely put patients in hallways in the emergency department. I don't know how we're supposed to have, as a patient, a great patient experience if you're stuck in a hallway bed. Here's one of my colleagues, John. He's a physician's assistant, and he's always kind of frustrated because this is where he works. This is his everyday hallway work experience. It gets loud. He gets constantly bumped by stretchers going right behind him. Worst part of it, he's positioned right in front of a restroom. So So imagine every time you got on a flight and you're on that back seat right next to the restroom. That's what his daily experience is like, and it really bothers him, frustrates him. I think it contributes to some of the burnout that he's feeling. And my favorite design fail, we routinely use fax machines to communicate and exchange data, because it's really, sometimes it's really only the securest way to do this. So Sarah Cliff, one of my favorite health policy journalists from Vox, said, "This is the cockroach of American medicine." So won't go away. I think healthcare represents the ultimate design challenge. It is the most complicated system and industry in the US. Our president figured this out when he tried to abolish Obamacare. Not that easy. I'm not going to that's the last thing I'm going to say about him. So the delivery of healthcare, it's just only one factor in making people and communities healthier. So there's the social determinants of health, or non-medical factors like education, income, the built environment, that have a far greater impact upon health outcomes than medical care. So it's this really complicated ecosystem. It's just not the care, it's not only just the care that's delivered in hospitals and clinics that make people healthier. So I think, I really believe in the power of design to simplify complicated systems. In my experience over the past 4 years of doing this, it really helps us to rapidly prototype solutions. Katie McCurry, she's an awesome user experience designer. She's embedded at the University of Vermont Medical Center. She's also a patient who's living with a chronic disease, and she shares of how frustrating it is to get these complicated hospital bills that are just really impossible to understand. So on your left is it's her own bill, actually. And so she created this prototype of a hospital bill that can be easier to interpret, and I think this is going to get implemented at the University of Vermont. Believe it or not, medical errors are the third leading cause of death in the United States. A medical student team of mine they're working on a project to reduce errors associated with patients being treated for sepsis. So here's one of their early prototypes for a checklist, just to ensure all critical actions are performed on a sepsis case. And the inspiration for this was from one of my patients that I saw in the emergency department who failed to get intravenous antibiotics and IV fluids before leaving the emergency room upstairs to an inpatient hospital bed, and unfortunately died about 12 hours later. I think prototyping has really helped us to get to solutions in a much quicker time frame. We have our medical students work with industrial design students. Here's one of the projects they came up with. They used scanning and 3D printing to create prototypes for an ergonomic bandage for patients suffering from chronic wounds. And they went from an idea to a functional prototype and a provisional patent filing within an 8-month period, but just by kind of using these skills of rapid prototyping and testing. So good design, I think, can really make the experience of healthcare better. And I really think it could help us, help really lead to better patient outcomes. The healthcare industry needs a design-centric culture, design talent, design leaders. I'm excited to be presenting with IBM because they've really been transforming their culture through design thinking and have great design leaders like Joni, Saylor, who have inspired me about the power of design to transform industries. So I'm going to invite Joni up.
Thanks, Bon. Take a seat in the guest lounge here. Hi, everyone. I'm Joni Saylor. I'm a designer. I'm an industrial designer, actually, by training. And, you know, as I've gotten to know Bon over, I think it's been about 3 or 4 years, our work tends to inspire one another. We've had great conversations about how, you know, is it possible that the lessons that we're learning in IBM to scale design and design thinking across our business really could help apply healthcare, help apply in the healthcare space. And so we've had many good conversations, and I hope that this turns into one as well. And so that's sort of the question that our friendship started with is, you know, can we learn from each other in how we scale and how we bring this approach into, especially into larger organizations. So speaking of large organizations, I'll just give you a quick backdrop into the IBM environment. So IBM, there's 380,000 people in the company, employees. We're in 175 countries. A normal team in IBM has about 50 to 300 people in it. Very normal to be in that large of a group, maybe distributed around the world. So you can imagine some of the complexity that comes with that. Of course, IBM's 106 years old, so a company that's been at it for some time, but very entrenched in terms of processes and culture and mindsets. And so obviously, work to be done to continue to evolve this place. And so I love to look back at some of the earliest products and design coming out of IBM, because when I started at IBM it was in 2003, I was an industrial designer coming out of school, had just been working on tons of interdisciplinary projects, and then I showed up to IBM and I saw a lot of artifacts from the past that were beautiful, right? There were even the most simple things that IBM had worked on were inspiring, and works of design and works of art in and of themselves, from punch cards, mainframes, typewriters, into the PC era, and on and on. There was a time in the 60s when good design at IBM was booming, and IBM was alive with great design that was connecting with people. And so I would find evidence of this in my office, or in sort of like old buildings that were built in the 60s and 70s. And then in my team, we would deliver products and services into the market that I wasn't as proud of, So that's where, for me, the journey of really embedding design and embedding myself as a designer into a larger organization became a passion and an ambition that I think, I hope that many more designers start to take that approach in their careers, in our careers, because certainly we hear from all the awesome talks that we've gotten to attend in the last couple of days that there's an environment for us here, and when we choose to engage in the systems of the world, then we're actually in a position to change them. So I'll just share quickly the story of our program. In 2012, we were looking to rebuild that culture of design at IBM. What could we do, looking back on sort of what happened with IBM's design culture? What could we do to rebuild it in a way that was sustainable, so that it could never die? And we started looking at kind of the past and where we were, and then a future that we wanted to go toward. And I think that's, when you start to look at it that way, it turns it into a design problem, right, immediately. So we knew, and we had a sense that we were, as many of our competitors were, ripe for disruption. We were on unstable footing, right? So we had many of the same problems and issues that Bond spoke of when he was talking about the healthcare space, right? We've got businesses within businesses within businesses that are siloed in their execution and in their strategy. We're hierarchical in our processes and in our org charts. We're very technology and solution focused, as opposed to being human centered and people focused. So wanting to, and then the market itself was moving at an ever faster pace, right? And here's big IBM trying to keep up. And so we knew that as we looked at this, this present state and this desired future state, we had some design work to do, right? We had to iterate on our own culture, on our own way of working. So we got started on that with this hypothesis that to bring design into an organization, into a large company or a hospital or a system, you can't just introduce design in the abstract or designers. There must be a culture that supports it, which is a big job when you think about it, right? So if we think about wanting to get to better outcomes, wanting to get to that to-be state where we have a culture that is sustaining great outcomes in a market, then we've got some levers that we can push, right? we can think about what are some of the facets of culture that we can really affect as leaders. Well, you've got people in your system. What do they believe? What do they know? You've got practices. What are their behaviors? What are their patterns? What are their habits? And then you've got places. I love the spaces you showed, Bon, and the immediate sort of reflections you have about sort of how the space actually is, drives work and supports different kinds of work and ways of creatively working. And so we really kind of went all in on this equation in terms of how to get from here to there. And so we started hiring designers. Our program is sort of known for hiring. We hired about 1,000 designers over the last 4 years, and just wave after wave. We've got like 12 of these cohort photos of designers coming into our business, right? Embedding into teams, working alongside engineers and offering managers in ways that they may not have ever expected. And as we brought them and as we hired more and more people in, we even hardened our perspective that designers belong not in an agency or in an agency model, but in the business, in teams, reporting into the same responsibility and management as everyone else. And so we've really entrenched ourselves in that belief that design, if it's to be introduced into an organization, it can't be sort of an other. It can't be a separate, different thing, sort of off in an innovation lab in a cool part of town where nobody else kind of gets to go. And so we made a lot of decisions that sort of started to support that model of embeddedness. And so that kind of brings me to, I thought I'd share a couple of our lessons that could potentially help in the healthcare space. One of the things that we learned is that as we started to bring designers into the business, we noticed that a lot of us, I'll say, really weren't ready in a couple of key ways. One, we were not ready to collaborate with people that are not designers and that don't understand design. Many of our designers are just not ready to sort of explain design and explain design approaches and design thinking to others. And that's a huge problem when you think about trying to embed designers in a big system. And so we did some work around that. We created a boot camp program that's 3 months of onboarding and helps to train and coach designers on how to be better at that. And then the second thing is around domain and around just this desire and a curiosity to go deep into the domain that we're working in. Something I noticed is that, because of our scale and because of all the hiring we've done, you see a lot of portfolios, right? And as I'm sure many of you you just see portfolio after portfolio. And a lot of students, a lot of teachers are just sort of self-selecting projects out of thin air that are just sort of a passion, rather than being sort of coached into domains that matter and parts of the economy and parts of business where designers can make a difference. And so I think for design students and for educators as well, there's a real responsibility to start to coach designers and up-and-coming leaders to embed and to care deeply about domains and become expert in them over time, of course, so that design and human-centeredness can have actual influence. And so today, as we've been at this for a while, right? We have designers working in education, in systems and hardware development, in cybersecurity, and they're starting to have influence. And this is a new quantum system from IBM. They're starting to influence healthcare. Watson Health has just a new business unit that's started to create offerings for nurses and doctors to try to help them deliver better patient care. 1,600 designers now are working in IBM, which was so crazy. Like, I just would not have thought that could be possible when I started as an intern, and there were like 100 all over the world. And so that, I think we are always trying to be careful when we talk about that, and because it's really, it looks like a big number, but it's like nothing, right? So if you think that's a lot of designers, well, I told you at the beginning, the rest of IBM is quite large, right? So how do we, as a profession, as a discipline, actually make a difference in a organization that big, in a system that big, which is quite a similar problem in the healthcare space. And so this is where we need a way to rally an entire company around design and user experience. And so an obvious choice for us was to sort of turn to design thinking as an approach. And so I'm like here to tell you that design thinking is not bullshit. It is a 21st century business skill, and we see it play out in our business every day in every team. After years of working to bring that practice into business and technology situations. And the thing about it that's really working for us, and I think is working for a lot of businesses, is that it paves the way for craft to actually thrive, right? So it's back to that thought that design can't sustain without the culture supporting it. So I really believe everyone is an artist, and I think anyone can be a design thinker, and that is the common language that now connects our teams as they work together. And IBM and our competitors as well. Many businesses across all different sectors are starting to see real return on investment, real growth. Forrester, Gartner, different analyst firms are documenting that this is not a fad. This is a way to gain competitive advantage. So I'll talk just quickly about design thinking and how we've sort of brought it into the company and into the non-designer space. We started out with this version of design thinking, which is kind of everyone's version. It's kind of a linear process, sort of laid out as steps that you might take throughout a project. And we found that in a continuous delivery setting like IBM, in an agile setting, this wasn't actually optimal. So I won't go all into it, but we started to rethink the way that design thinking can be applied in teams and what it is that we're really doing when we continuously deliver. And we introduced a really simple concept that in every market, in every team setting, there are three things that you're doing. And anyone in a team doesn't have to be a designer, can see themselves in at least one of these activities. You're observing people, you're observing markets, you're reflecting, and you're making. And when we reflect, we're doing these in, you can do them in any order, but as long as you do all three at least once in a project, you're going to get to a better outcome than you would had you not. And so one of the things we found is that simply observing, simply bringing users either into our work or into our conversation is the quickest way to jumpstart a team into being more user-centered. As we've been doing this for a couple of years, we've seen that the number one thing for a team to do to start being more user-centered is to bring their users into their work. Go talk to them, have their voice be represented. Anywhere in the project is the place to start. And so when we talk about reflection, we're talking about aligning many different kinds of disciplines and experiences across a team, right? So what are we solving? What's most important here? And I think what I love about this image, this is a big workshop that one of our teams did about a year ago. And something I love about it is that you actually can't tell who's a designer and who's not a designer when you look at this. This is a very mixed group of engineers, product managers, designers, all working together. There's a couple of their users in the back corner, and you can't. This is a practice that's being built for everyone. And then finally, making. So we talk about making a lot in design, but there are many professions that make. Engineers are makers and are creative. Product managers are makers and creative. People in sales, marketing, we all have a medium where we make. And when we do it together and when we make with intention, we have a lot better chance of putting something out that's well received. So we can make in prototypes. We're making in code. We're making beautiful animations. But just bringing back to this concept of
observe, reflecting, and making continuously it has been for us a really powerful way to introduce this concept super simple so that anyone can kind of pick it up and start using it. One of the things that we've learned, and I think is a very transferable thought into healthcare, is that teaching design thinking to different disciplines and across different kinds of leaders in the abstract, sort of in a case, fake case sort of approach, is way less effective than bringing design thinking directly into project work. So I'll share just a really quick story. I'm not going to go all into the details here, but just to show you that the way that we can kind of quickly and easily embed design thinking. It doesn't have to be a huge organizational scale effort. You can start at the project level with just a few key roles and types embedded. And so this is a project actually that my colleague Chris Hammond worked on last year, and I wish he was here to talk about it, or to hear us talk about it, because it's like his favorite thing to talk about. He was part of the program at IBM called the Health Corps, which is kind of like the Peace Corps for health, and it's something that IBMers can sign up and go do. Well, he ended up getting sent to Taiwan to work with the CDC there, the Center for Disease Control. And they came to IBM with a really simple ask, right? They came to a little small team of 6 leaders in engineering and math and business design, and they said, hey, IBM, thanks. All we need here is an effective predictive model to help us anticipate dengue fever outbreaks. Huge problem in Taiwan, and they were, at the time, they were really in the throes of dealing with the volume of dengue fever cases. And so, what does a designer do? What does a design thinker do when they hear that prompt? Well, old IBM would have heard that and said, cool, we got you. We're going to send out a couple of mathematicians and a scientist and a writer, and they're gonna figure this out for you. But new IBM, and I think the new business response, not just IBM, is to go observe, to go figure out, go talk to people, go reframe a technology or a technical prompt into a human problem. And so that's what they did. They went out into the field and they talked to people who were learning and collecting and creating the data that describes the dengue outbreak and feeds decision makers. They reflected, right? They brought together people from 7 or 8 different silos within the Taiwanese government, healthcare system, and education system especially, to come together, reframe the problem around a person, and then suddenly these very different people with different disciplines have one thing to talk about, and it's human needs, human wants, human expectations. And so I won't go too deep into their solution, but just wanted to show sort of the approach in action here. What they ended up making wasn't an algorithm, it wasn't a model, it wasn't a mathematical model. It was a system that takes into account the natural, human, and environmental factors in the system, and enabled people to better be in control of the information, to enable people to make better decisions about how to invest in lowering dengue outbreaks. And so the thing I would point out about this that we've learned that I think is really transferable across businesses and across different kinds of organizations is that, when you're thinking about bringing design thinking in at the team level, the pattern that we've seen that's really successful at the team level is 3 things. It's always three things. It's about, first of all, having co-creators, people in the lower right there. These are engineers, they're mathematicians, they're designers, they're scientists, they're policymakers, they're educators. But the common language that they speak is design thinking. They understand at its core. They may not be expert design thinkers. They may not be able to drive a project, but they're dedicated to being focused on people and users. They're dedicated to working in an interdisciplinary team, and they're committed to this idea that everything's a prototype. We can continue to iterate and make it better as a group. So that group, those co-creators in a culture, they sort of sustain a human-centered way of working. And then second is this advocate. So this is the executive director of the Taiwanese Center for Disease Control. She, at the start of the project, didn't want to do design thinking, really. She didn't think it would work. And when she started to see different silos across the Taiwanese landscape come together and really want to focus in on her problem, she suddenly was, okay, maybe this is going to work for me. And since this project, she has actually commissioned a program to introduce design thinking across all of the Center for Disease Control in Taiwan, which is awesome. And then you have this coach, and that's Chris, my colleague that I was sharing about. I think it's fun to notice that he's totally turned around and you can barely see him, and it's like a picture in a picture, because this is the person who is, sort of the tireless designer, design thinker type, who's going to, embed him or herself and try to make change. You can never catch a picture of this person in a workshop, right? Because they're always running around. But you might think that to introduce design and design thinking into a large system like this, that you need everybody to be operating at this level. You need everybody to sort of be ready to lead. And that's not true. This is one person who is, admittedly a pretty exceptional guy, who was able to influence about 100 people at the project level and rally this large group around the idea of being human-centered, solving real problems, and prototyping. So we've actually started to, in IBM, we've started to shape our education and enablement for all employees around these three concepts for the most part. So what can we do to help people be an advocate for the user? How can we help people co-create? And what kinds of support can we give to coaches? So I'll wrap it up, but I think one of the lessons that we learn from that story and from many of the more complex projects that we've taken on is that this idea of silos has been it's been vexing businesses and large organizations for a century as they've grown and evolved, and all the processes and complexity has wrapped itself around that. And I think what we're starting to see is that a major step that an organization can take to combat that is to break through those silos by really literally ignoring your org chart and reorganizing yourself and your teams at scale, or at any scale, around the user and around their journey. So I'll wrap up, I guess, but bonus thought is that if you can't tell from everything that I was sharing and that Bon was sharing, I think this idea that I liked the way that John Maeda was framing sort of these three kinds of designers, and I think there's room for all three of those kinds of designers in the world and in craft and in every kind of business. But there's not room for one kind of designer, and it's like the lone genius type who doesn't want to co-create or be in a team. Or deliver together, because the challenges we face in large organizations and in complex problems are just too tough for one person to deal with. That's where we are in technology and in the 21st century. That's what's happening. So this era of the lone genius is over, and it's about teams. Teams are the fundamental unit of change. So, thanks.
So we'd love to invite folks to come out to the mic in the middle, and we have a few minutes for Q&A.
Great presentation. Thank you very much. Joni, I wonder if you could talk a little bit more about getting buy-in from the decision makers and the managers that were actually implementing the changes that you recommended. It looked like you had an inclusive group that was kind of multidisciplinary, coming up with a new design way of thinking. What was effective in pitching those ideas to people who maybe were against those changes? You showed the CDC director that was originally against that, but then was an advocate over time. How are you effectively approaching decision makers with IBM? And then also, do you think the same approaches would be effective in healthcare?
Sure, yeah. I think first and foremost with that group, they want stories of success. And so one of the things that, like, I left it out, but our whole program started because our GM for design had a really successful startup that IBM acquired, and the rest of the business leaders near him, they didn't really know why he was successful. They didn't know why that business did so well. He did. He knew that he cared a lot about, being human-centered and et cetera. But they knew they wanted that thing. Whatever that thing was, I want market success like that. And so as we've started to build up a set of kind of case examples for executives and other leaders to see and learn from and sort of aspire to, that's been a very effective tool. And then I think the other thing that we've started to invest more in is just this idea of metrics, return on investment, and measuring sort of the before and after. So I'll let you.
And we just try to go for really early wins and show those examples to leadership and not invest so much time and money and effort into one particular project. But I think it's really important to go, hey, we applied this creative design thinking process and came up with this solution, and to be able to show that to leadership.
A lot of what I heard this morning was designed from the perspective of the doctor and the hospital, or the perspective of IBM. Who's looking at the design of American healthcare from the perspective of the patient? Because in many cases, 70% of all sort of care-seeking concerns can be dealt with over the phone. And who's designing that model that will keep people healthy and out of the hospital?
Sure. What this process, I think, really has helped us with is bringing in the patient into the conversation. That hasn't always been the case in medicine, which has been very paternalistic. It's the conversation goes between the provider, me, and the payer, which is the insurance company. Kind of don't even need the patient because the patient doesn't even pay the bills, right? And so that's how, for years, that's how our system has been built up. But this process forces us to really interject the patient's voice into different solutions that we're coming up with. So it's been really helpful. Sometimes it's jarring because one example that we did was we were redesigning part of our emergency department, or thinking about that. And I said to leadership, I was like, well, instead of having a bunch of us executives around a conference room table, why don't we bring a patient who's actually been through that part of the emergency department? They were like, wow, that's an innovative idea. I'm like, what? I mean, so it's mind-boggling how for so long we've thought about not designing for that end user. So, and for telehealth, definitely, patients don't want this brick-and-mortar delivery system where this Blockbuster model, they want the Netflix model. They want to be able to get care where they need it at the most convenient time, and we're seeing a lot of telehealth solutions built up around that.
Hi, my question is very related to that. I'm a designer on healthcare systems, and I often find that the needs of the patient are the opposite of the needs of the clinician or the doctor. For example, in an examination, the doctor wants to ask as many questions as possible in the shortest amount of time, whereas the patient wants to feel safe. Maybe they want to go slow. So when I work and I consider the user needs, it's difficult to put those two opposites together and design a solution that works for both. So I was just wondering if you guys had any insights on, I guess, where do we weight our kind of priorities, which will give the biggest returns?
Yeah, it's hard, right? So the way I have made money and the way health systems have made money by seeing as many patients as possible, doing things to them in the shortest amount of time possible, right? So that's how the fee-for-service payment model is built. And so there's been a lot of payment redesign on bundled payments and paying for quality rather than quantity. And I think this is an interesting time because right now a lot of us are kind of confused in healthcare. A lot of these payment models are changing so rapidly. So we're going from this like I need to see like 60 patients a day in order to make, make an income versus like, oh, paying for quality. And so it's an interesting time. I think the whole healthcare system is blowing up. I mean, it is a large industry, right? So last year, healthcare surpassed retail as the largest source of jobs in the US, and it's projected that a third of all jobs in the US are gonna be related to healthcare. So there's no easy answer, I guess, to that, but I know it's a very kind of confusing time right now.
I would just add that when you talk about opposing constraints like that, which there seem to be a lot of in healthcare, from the examples you showed as well, Bon. I feel like that's where the designer comes in. Designers and the design mindset can look at opposing constraints and sort of find new approaches that fit within the system. And I think that's like it's an easier said than done thing. And where, I wonder about the ways that service design tactics especially can really fit in to the healthcare system, because they're where you have so much complexity and where you need sort of a blueprint that goes, 5 or 7 layers deep from the user. You can bring in service design tactics to kind of figure out, well, where is the waste in this system, and how can I take that out so that I can maximize the needs of the user against the needs of business? Yeah.
Hi, thank you for sharing all your insights. That was great. I'm a UX designer for ultrasound systems, and I think we're all in vehement agreement that healthcare is like ripe for design insurgents. But for me, the biggest thing that always comes up is that there's a whole bunch of constraints that regulatory boards and things like FDA and all that place on it. So I am always curious about how can designers and healthcare providers like collaborate to sort of work around that so that that doesn't hamstring our innovation?
I think embedding designers in every part of the process. And what's exciting, I see these health systems having design teams, hiring service designers, UX designers, experience designers, and having them with every step of the process. I think it's been extremely helpful getting around, thinking out of the box on these kind of regulatory issues that we face. And it's not often when if we do bring in designers, it's kind of like too late. It's kind of like, at the end, but I think getting a design team in the early part of the process has been helpful.
Thank you.
There's so much complexity in these systems between humans and large organizations and everything. And you mentioned a little bit about looking for quick wins. I'm just wondering if there are any other specific suggestions that either or both of you had about how to keep our teams focused on simplicity. Because at least in our business, we found that some of the most powerful solutions are the ones that are the simplest. How do you help your teams to keep things simple and look for quick wins?
Well, we don't actually focus on simplicity as much as you might think in the way that we talk about design and designing relevant solutions for people. I think at the end of the day, it starts to be about building teams around problems or a prioritized set of. At IBM, we think about it in terms of like jobs to be done. So one of the things that we've been doing is we've started to map out kind of a star chart, if you will, of what are the prioritized set of if as a business we've got 10 things to really care about this year, what are they? And they better align around a user or a market opportunity. And not around just technology that we think is interesting to push into the world. And so I think it, at its core, it starts to be about figuring out as a company how quickly can you form teams around real user problems versus all the other kinds of complexity and kinds of innovation even that you could pursue.
I guess for me, it seems like the magic bullet in healthcare, and especially kind of like the conversation I've been hearing around South by this week, is like AI comes up in every single talk, it seems like, right? And then kind of like big data is we're going to win with that. But you know, it frustrates me a little bit because the numbers are so bad out there, you know, and you know, the opioid crisis and the amount of Americans dying from that, and just we get bombarded with these depressing statistics. And for a lot of us in healthcare, we're like, we can't even do anything about it. It just, and so what we try to do is kind of really humanize the data and bring it down to like to a sample size of one and focus in on the end user, because I think for us, they just become numbers sometimes. So what I do a lot in our program is really try to focus on a few end users for a particular problem, and then storytell around that, because data doesn't move people, but stories do. And yeah, so that's what helps me to simplify things in our organization.
That was a great quote. Data doesn't move people, but stories do. So I'm actually a researcher, and I've done some design thinking techniques at my company. I work for a healthcare company. We have 80 million members, or patients, users, and doing research. We have analytics. We've done surveys. We've done interviews. We've decided to come up with personas because the company's new to design thinking and design. And so when you're kicking off these projects, what's your take? I mean, how do you implement research in that beginning phase when you're doing creating the empathy and you're doing the observations and the reflection? How does research play into that?
That's a great question. A couple things. One is that we focus a lot on doing research continuously. So if we've found that if as a team or as a portfolio, we position research as something that's kind of heavy and upfront that you do before you make decisions or before you make something, that's a great way to dissuade an executive from investing in research. So one of the things that we do is we advocate for research throughout, right? That being said, there certainly is a moment for understanding as a project is coming together, as a team is forming around a problem, or trying to identify a problem. And so I think for us, we have teams all over the place that use personas and hate personas, and there's just different religions on personas, I guess. But I think what matters at the end of the day, from a business perspective, what matters is codifying the patterns of behavior around a given problem or market. And if you use personas to do that and you want to invest and keep them up to date, then good. But if you create personas and they turn into sort of a static sort of meme for a team, then you miss out on the benefit for continuously informing the direction for whatever it is that you're delivering.
And I really appreciate how design allows me to do like ethnographic research, and traditionally academic medicine research is done in randomized controlled trials and with big data sets. And sometimes I'm like, well, can I just like talk to people and figure out what's going on with them and visit them in their homes? We had one patient who was a super utilizer, visit the emergency department about 200 times a year, literally. And then we're trying to figure out what to do. And I actually went to South Philly and visited his house. And most of our staff thought he was homeless. I'm like, no, he has a home, he has a couple of kids, and just really kind of understanding the human story behind the patient really, I think, is helpful, that we can't get from just looking at a data set. So I think having a design-centric approach gives me the opportunity to do that in a way that I didn't have that freedom to do it before.
Okay, I think that's all the time we have. Thank you all.
Yeah, thanks so much.